Emergency visits for sickle cell. What should you know? When it comes to sickle cell disease, emergency department visits can be quite common. These visits often happen due to acute complications, especially severe pain episodes known as vaso-occlusive crises. Other serious issues can also arise, such as acute chest syndrome or infections. Knowing what to expect during these visits can help improve outcomes and make the experience smoother for patients. One of the main reasons individuals with sickle cell disease go to the emergency department is due to acute pain crises. This pain occurs when sickled red blood cells block blood flow, leading to intense discomfort. Other emergencies include acute chest syndrome, which is a serious lung complication, fever that may indicate an infection, stroke symptoms, or severe anemia. Recognizing these complications quickly is crucial, as some requiring immediate treatment to prevent serious health issues. Once a patient arrives at the emergency department, they will undergo a rapid assessment. This includes checking vital signs like pulse, blood pressure, temperature, and respiratory rate, as well as measuring oxygen saturation. If oxygen levels are below 95%, oxygen will be provided. Additional tests, such as arterial blood gases, may be done if oxygen levels are low. A thorough history and physical examination will focus on pain severity, signs of infection, and any neurological symptoms. Laboratory tests, including complete blood count and blood cultures, are often ordered, along with imaging like chest X-rays. Pain management is a top priority in the emergency department. Guidelines suggest using weight-based or individualized opioid dosing, with opioids administered quickly after triage. Pain should be reassessed every 15 to 30 minutes until it is under control. Non-opioid analgesics, such as non-steroidal anti-inflammatory drugs, may also be used for mild to moderate pain. In children, intranasal fentanyl can be considered for rapid relief. Timely pain management is essential, and patients with sickle cell disease should be given high priority during triage. Fever in patients with sickle cell disease is treated urgently because they are at a higher risk for severe infections. Broad-spectrum antibiotics are typically started promptly after cultures are taken, especially if a central venous catheter is present. Decisions about admission depend on a risk assessment that includes clinical signs, lab results, and social factors. For patients who do not meet low-risk criteria for complications or who have severe symptoms, admission for further treatment and monitoring is usually necessary. Those who meet low-risk criteria may be discharged with clear follow-up instructions and guidance on when to return. Coordination with hematology specialists and having an individualized care plan can improve management and reduce unnecessary admissions. It is also important for facilities to have protocols for quickly transferring patients from places with limited resources to centers that specialize in sickle cell disease. Patients and their families should know how to access urgent care and have plans in place for emergency situations. Education on recognizing early signs of complications and knowing when to seek emergency care is vital. In summary, emergency visits for sickle cell disease requiring prompt and specialized assessment and treatment. The focus should be on rapid pain relief, infection control, and monitoring for serious complications. Effective communication between patients, emergency teams, and hematology specialists, along with individualized care plans, are key to improving outcomes during these acute episodes. Always consult healthcare professionals for personalized medical advice.